Hi, this is the Epidemiology and COVID-19 part of a recent grand rounds that I gave at the University of Illinois at Chicago. I'm trying to address a few basic questions in this talk. First of all, what is a pandemic? Two, why is social isolation so important for the COVID-19 pandemic? And why is coronavirus so contagious? Definitions to start with. An epidemic is the occurrence of more cases of disease than expected in a given area or among a specific group of people over a particular period of time, and it usually refers to influenza. An outbreak is the same definition as an epidemic, but over a limited geographic area. A pandemic classically refers to when a novel influenza virus A emerges, which is able to infect people easily and spread from person to person in an efficient and sustained way. For those of you who are not familiar with influenza A viruses, this is just a brief summary. Basically, there are two proteins which differentiate each influenza A virus from another influenza A virus, well, a strain of it. The two proteins are H and N. There are 18 subtypes of the H protein and 11 subtypes of the N protein. And a influenza A virus will be referred to as a combination of these two, such as H1N1 or H9N2. These viruses are fairly predictable, but can occasionally undergo major changes. First of all, when the genetics, this genetic sequence changes so that if you remove one or add one, for instance, it will shift the entire genome, and that can result in a whole bunch of new proteins, which will then create a new virus. You can also have genetic reassortment, which is when a human virus exchanges information with a non-human virus, such as avian or swine. The difference between a seasonal flu versus a pandemic is basically that the seasonal flu can be predicted. For instance, it generally starts each year around Chinese New Year in China, which is spring there. And then it makes its way around the world, eventually ending up at the United States in the fall. We're actually lucky because of that, because we're able to obtain the first strains of the flu virus as it emerges, and then we can be prepared by having a vaccine for when it reaches us. A pandemic flu is very different. Basically, because of the way it happens, it can't even be predicted. So we can't be prepared for it by definition. I wanted to show you a case study of the 1918 pandemic, which most people have probably heard of. It turns out to be an H1N1 flu. This H1N1 flu emerged originally during World War I, and the spread at that time was worsened by overcrowding and global troop movement. There was a lack of vaccines and treatments at that time, and there was no pharmaceutical intervention available. All told, approximately 500 million, or one-third of the world's populations, were infected, with at least 50 million deaths worldwide and approximately 675,000 of those in the United States. The mortality was highest in the under 5, the 20 to 40, and the over 65 age groups. And there was a high mortality in healthy people. Actually, the pandemic timeline starts before 1918. It started in 1917 in June, when the United States entered World War I, at that time with 378,000 armed forces. A draft was established almost immediately, and 32 large camps were started in the United States, each with between 25 and 55,000 people. And you can see this is what their hospital areas look like. All the pictures, by the way, are from the CDC website and in their 1918 flu section. So in March of 1918, a flu-like illness appeared in the camps in the States and in Europe. And in April, there was global troop movement. And I will show you how these hundreds of thousands of soldiers crossed the oceans in a few slides. Basically, the second wave of the flu began in the fall of 1918, which was highly fatal and responsible for most of the deaths. And by October, there were 195,000 Americans who were dead of the flu, with a severe nursing shortage. Cities were closing gathering places, and several places had cold storages that were converted to morgues. New York City showed a 40% decline in shipyard productivity due to the flu during a wartime. This is just a picture, might look familiar, of Boston Red Cross volunteers who were helping to assemble gauze masks. At that time, a large number of the physicians and the nurses in Massachusetts were in the military service, and every able-bodied person with any medical training in Boston and that area was called into service. In October, Congress approved $1 million to hire more physicians and nurses. This is just a picture, again, probably looking slightly familiar, of a barber in Cincinnati wearing a mask, signs that were around. This is San Francisco, which was probably warm enough to be able to have an open air police court. You can see that these people are not standing 6 feet apart. In New York City, the street sweepers were moonlighting as grave diggers. In St. Louis, there were volunteers who were driving nurses from one quarantine house to the next to take care of patients. And this actually allowed 40 patients to take care of 40 nurses to take care of 3,000 patients. And I think I calculated that to be about 75 patients per nurse per day. This is the picture I was talking about. At the end of the war in November of 1918, there was another wave, the third wave of the flu. At that point, we had 4.7 million soldiers in the war, and this is how they came home. So packed on these ships. At that time, the public health community started educating people about sneezing and coughing. The factories and stores began to stagger hours to avoid overcrowding. And in January of 1919, the third wave of the flu was reaching maybe not peak levels, but pretty high levels. And for an example, in San Francisco, during the first 5 days of January, there were 1,800 reported cases with 101 deaths. And by February of 1919, it was thought that the flu was nearly eradicated. But in April, when President Wilson was at a peace treaty negotiating at Versailles, he did collapse, and some historians speculate that he was weak from the flu, which was still rampant in Paris at that time. Since the 1918 flu, there was a large movement actually called preparedness. And I wanted to show you between the 1918 pandemic and now some of the steps that have been taken in terms of preparedness. For instance, in the 1930s, influenza viruses were isolated from people, which was important because up until that time, there was a concern that it was actually a bacterial infection. So actually being able to isolate it proved that it was a virus. That was important because then people were able to develop the flu vaccination. They went on to develop influenza B, and this led to a bivalent flu vaccination, which includes both A and B strains. The first generation mechanical ventilators was developed. The Centers for Disease Control and Prevention was established in 1946, and the World Health Organization was established in 1948. In the 1950s, WHO established a global health response system for the flu, and the CDC had an influenza branch that was established for the surveillance, epidemiology, and control of the flu. This system was tested in 1957 by the H2N2 pandemic, which led to 1.1 million deaths globally and about 116,000 of those in the United States. So in the 1960s, we continued in our preparedness. The annual flu vaccination was recommended for certain groups of people. Amantadine made its appearance and was licensed as an antiviral. And the first connection between the flu and the avian flu was established. Another pandemic in 1968, the H3N2 pandemic, again with approximately 1 million deaths globally, with 100,000 of those in the United States, mostly in the over 65 age group. In the 1970s, there was a swine flu outbreak. This was important because about 25% of the United States population, or 48 million people, were vaccinated against this flu. For those of you who have not heard of herd immunity, that is a public health term. It's referencing the number of people you would have to have vaccinated in a population to avoid transmission from, say, A to Z in a room, because you would have all these people who are not, maybe not in a room, but in a row, you have all these people who are not susceptible to the flu in between. So it becomes very difficult to transmit it from one end to the other through people. So with 25% of the U.S. population vaccinated, it was actually estimated that about twice that number, or 50% of the population, needed to be vaccinated to provide protection for the at-risk population. Part of the reason that the flu vaccine was slightly impeded, or maybe more than slightly impeded, was that cases of Guillain-Barré syndrome were reportedly associated with the vaccine. However, by the 1990s, Medicare started to cover the cost of the flu vaccine. Several other antivirals, Remantadine, oseltamivir, which is Tamiflu, and Ranamivir, were licensed and approved by the FDA, and then licensed for treatment of the flu as antivirals. The first human case of the avian flu was identified, and also the swine flu became established and was monitored. In the 2000s, there was an advisory on vaccination, which was created and started to recommend vaccinations, expanding to younger people. The nasal flu, which is a form of the flu vaccine, which is alive, was licensed. The entire genome of the 1918 flu virus was sequenced in the 2000s. The CDC, and this is important, established an influenza reagent source. It's a resource to provide reagents, tools, and information to test for the flu virus. In 2004, the National Incident Management System, or the NIMS, was established by FEMA for all branches of the federal government. And this was supposed to sort of establish not a generic, but a prototype response in any branch of the government for an emergency. And these steps included preparedness, communications and information management, resource management, command and management, and maintenance. And then in 2007, the Pandemic Preparedness and Response Intervals Framework was established. And this is just a picture of it, also from the CDC resources, which shows this framework being divided into 6 separate sections: investigation, recognition, initiation, acceleration, deceleration, and preparation. Right now, in terms of the COVID pandemic, it looks like we're still kind of in this area. These intervals were defined and have specific prescribed public health actions that are recommended to be taken during each interval. So this brings me to my next case study, which is the 2009 H1N1 pandemic, another influenza virus. What's amazing about this is I'm just going to show you the first 10 days first of this pandemic, and you're going to be able to kind of compare in your head probably with what is happening now with our pandemic. The first case was reported in the United States April 15. The second case was reported 130 miles away from the first case with no known connections, and that was day 3. By day 4, these cases were reported to WHO, and by day 6, the CDC began working on a vaccine, using a vaccine candidate. The 23rd, there were more cases, which meant that this was now a multi-state outbreak. And on the 24th, which is 9 or 10 days, depending on how you count it, the CDC uploaded a complete gene sequence of the new virus onto a publicly accessible international influenza database. This is important because it means basically anybody around the world who is interested in working on this virus had access to the genetic database. And then by the 25th, WHO declares a World Health Emergency. As you go on, the 26th, this is important again. The CDC started to release 25% of its stockpiled antiviral drugs that were needed to treat influenza virus. And they also, around that time, released over 39 million PPE to the 50 states in order to help them with preparedness for the pandemic. By the 28th, the FDA had approved a new CDC test to actually detect the infections. And that's important too, and I'll explain why in a minute. Well, maybe now. These tests were actually shipped out. And what happens is when you send the same test all around the world and the country, when I refer to X number of people testing positive, everybody has the sense of how many people that would mean who were positive by accident, a false positive, and how many people who were missed who should have been positive but tested negative, that's a false negative. And then we can compare all of the numbers across, and it means the same thing everywhere. Schools were closed. There was a pandemic, which I don't know how many of you remember it even. It was so quickly dealt with. And then by the summer, and this is probably why any of you who had your summer camps canceled, this is part of the reason, because summer camps are little beautiful places for outbreaks of epidemics or pandemics or whatever virus is going around at the time. By July, strains that were resistant to the antivirals were starting to be detected. However, also by July, tests were starting to happen for a vaccine. And the second wave of the flu started in August, which is about the usual time. As you can see that the reporting season started on August 30th. So by September 1, there had been over 1,000 test kits that had been shipped to the world and to the United States. This is important too, because with it probably comes a recipe on how to make it and reagents if you needed them. By September, there were 4 approved vaccinations. We started placing the orders, and in October, the first dose of vaccine was given. That was, let's see, it started April, May, June, July, August, September, October. So 6 months out, we started with the vaccine in the general population, or for whatever targeted groups they had. The president at the time encouraged vaccinations by starting with the vaccination week. And then by August, WHO announced the end of the pandemic. So you can see this was very different. Things that had happened since then now, and I list this because it kind of bridges because it was further developed, but the Pandemic Preparedness and Response Intervals Framework was developed in 2007, which is before the 2009 pandemic. Then there was the IRAT, which is the Influenza Risk Assessment Tool that was developed in 2010. This is listed on the CDC website, and it goes into much more detail. It's basically used to monitor viruses that have a pandemic potential. There's also the Pandemic Severity Assessment Framework that was developed in 2017. And again, this is used to help to predict viruses which may result in a pandemic. Other public health preparedness strategies in the United States, the government developed a school closures policy. The CDC established and took, this was a summary. One of the things that I wanted to point out was that the CDC established and took a lead role in the United States and in the world in sequencing the virus, developing and sending out test kits, developing the vaccine, and then monitoring disease spread and strains of the virus. The WHO was established and helped keep the world informed at that time. So this leads us to the present pandemic. And I mentioned this because the slogan for the Corona beer, which I didn't know, it says miles away from the ordinary, which kind of describes what's happening. In these following slides, you're going to see a lot of pictures from the Chinese newspapers. And I just thought this was a very interesting way of looking at the pandemic, both from an international view and sort of how they saw the United States approaching this pandemic. So the very first case was reported or found, or I guess maybe established to be on November 17th. It was not recognized at the time it showed up. And actually, in retrospect, they're still wondering if there was an earlier case. So far, no one has found one. By December 1st, the first known patient started having symptoms, and there was no link that was found between this case and later cases. However, in the middle of December, 7 novel coronavirus were documented in a cluster. And you'll note that of these, only 2 were linked with the seafood wholesale market that is often, or was often discussed at the beginning. And then these pictures are of Chinese New Year in China, and I really wanted to show it because usually these streets are jam-packed. They're wall-to-wall people, and they are empty because China was in quarantine at the time. I'm taking a quick sidebar. This person is worth knowing about, and he was very brave. Dr. Wen Liang, who's an ophthalmologist in Wuhan at the time, tried to report 7 patients on social media, and he was initially reprimanded by the government and forced to sign an apology and whatnot. However, sadly, on January 10th, he developed a dry cough with a fever, and on the 14th, he was admitted to the hospital with his parents, who also contracted the coronavirus. So the 3 of them were admitted together. On the January 30th, following a whole bunch of negative tests, he had a positive test, and then in February he died in the hospital. Due to pressure from the people, the Chinese government awarded him a posthumous award. So timeline of this coronavirus, it was not until December 31st that the CDC was alerted to an unexplained cluster of cases of pneumonia in Wuhan. That's about 6 weeks after the first case. In January, the Chinese scientists were looking at the genetic sequence collected and found 3 distinct strains. By January, the United States, the CDC issues a level 1 travel watch, which is basically practice usual precautions. And on January 8th, scientists in China announced a discovery of a new coronavirus. The sequencing of the genes was isolated and posted on virological.org by researchers from China on January 10. And since after that, things happened more rapidly. There were person-to-person cases confirmed. The Wuhan Institute files to patent remdesivir, which you may have heard of by now, which is an antiviral. What's important is on January 18, Wuhan, which is the 10th largest city in China, and apparently the center of a kind of ideal community, rewarded their community by holding an annual Chinese New Year banquet with 40,000 families in attendance, and this group of people shared food and plates and dishes and whatnot. So in retrospect, this was kind of scary thing to do at the beginning of an epidemic. Chinese government shut down all the public transportation from Wuhan. Depending on what news source you follow, apparently possibly many tens of thousands of people managed to leave Wuhan before it was shut off from the rest of the country. And then Wuhan itself suspended all city transportation. This is important. The city began construction on an emergency hospital. I'm going to come back to that in a minute because it's pretty impressive, no matter how you look at it. It wasn't until January 24th that the United States had the second confirmed case, and I point this out because it was in Illinois. It was a woman who went back to Wuhan to take care of her parents who had been sick and then came back, and apparently when she found out, she self-quarantined pretty quickly after letting her doctor know. This was a very nice way of doing it. The Chinese New Year holiday in China, instead of saying that they were quarantined, they extended the Chinese New Year, which is normally about 30 days. CDC begins to expand its travel advisory, and then we close our borders to all foreign nationals. This is kind of interesting. By February 5, Wuhan has reported over 10,000 cases. The United States confirms its 13th case, who was an evacuee from Wuhan. This picture just looks so much like the other picture from 1918 that I had to show it. And this is really scary because I think they're showing the contrast. I can't remember if this was when it was thought that the coronavirus might be a hoax. But you can see that they have all of these people in masks and taking it very seriously in China. And our president basically telling people not to worry. By the 21st of February, this is really frightening because it's just over 3 months since the first case. The United States Association of Public Health Laboratories releases a report and says that only 3 states in the United States are capable of testing for the coronavirus. And then on March 11, WHO declares a pandemic. This is the hospital I was telling you about. That emergency hospital that Wuhan was building, this is it. And it actually was 2 hospitals. It was built in 10 days, which is truly amazing. Again, no matter how you look at it. And this is how they did it. Apparently, this is how they break ground, and this is how they brought in all their supplies. It's a major effort. This was one of the first patients, and you'll notice that everyone is decked out in full PPE. As of the May 28th, which is the last time I gave this talk, there were 5,800,000 plus cases with 358,000 plus deaths, and 2.5 million or so people have recovered around the world. At that time, there were 2.9 million active cases, 98% of which were mild, and then 2% which are severe, which is still 53,000 people. Closed cases, which either means you got better or you died, there were 88% of recovered and 12% of deaths. I'm showing this because May 3, only 3.5 weeks before May 28th, this was the number of active cases in the world, and it had increased more than tenfold. And I think more importantly, actually, really, truly, is the number of mild cases went from 95% to 98%. Important. And also the number of people who have recovered went from 80% to 88%, which means the death rate was dropping. That's just showing that the deaths parallel the cases. This is the first time I gave this talk, actually, or the first version of this talk. And again, it's just a comparison, but at that time, around the world, there were 532,000 cases, so 500,000. And by the 28th, 2 months later, approximately, there were 5.8 million. It's really frightening. And this changes, I think it may change based on which countries in the world are most involved at that time. If you look at the data, I'm fairly certain it'll show that. The number of active cases has also risen dramatically. The number of mild cases, the percentage has done nothing but go up, which is really good news. And then the percentage of those recovered has gone up, possibly in parallel. I'm not sure. I haven't plotted it out. I put this up because, again, on May 28th, the United States was leading the world in the number of total cases, as well as the number of total deaths, and maybe the number of total people recovered, which is good. Still have the most active cases in the world, and with 17,000 in critical condition. There was some statement in the press about how we lead the world in testing, and it's true right now. We have administered the most tests, and we also have, except for China, the largest population. I put these other data up. It was more important at the beginning, but the Diamond Princess was the cruise ship that was stuck off the coast of Japan. I think it had about 35,100 people, and roughly 1 in 5 or so got infected, and with 13 deaths. Vatican City is even involved. Nobody is exempted from this. As of May 28th, May 25th, on the New York Times, this is what the hot spots look like in the United States. Truly frightening. It looks like somebody with really bad measles. The question is what went wrong between 2009 and the pandemic now in 2020, uh, when everything had been getting better and better. Why are we now back in 1918? There are many, many possible explanations. It's clearly multifocal. Possibly one of the most recent um, but important things that could have impacted the ultimate results was the pandemic response team, which was the Global Health Security and Biodefense Unit and responsible for pandemic preparedness, was disbanded in May of 2018. It's not sure what's happened to all the members, but some were let go and some were rejuggled to other units. In This is another thing. I got these from the newspapers, and so it's very hard to verify exact numbers. But for people who don't know, the CDC has officers embedded with the permission of the countries who have them embedded in, has embedded in other countries. So, for instance, there were representatives to the Chinese CDC, and depending on which report you read, there was a unit of 41 people that by July of 2019 was down to 14. And at that point, apparently, the administration fired the leader of the unit and did not replace her. This was potentially very important because this was, you'll notice, about 4 months, I think, August, November, 4 months prior to that first case. And probably, you see, our role in these other countries is often to serve as an advisory capacity and also to show them and help with epidemic investigations, tracking them and monitoring them, surveillance, etc. And so it's thought that that unit, or at least that leader, should have had boots on the ground and been able to give a report of that first cluster of 7 people in December for sure, and possibly most probably obtained a sample of the virus for our CDC to begin to analyze. And then finally, this again came from newspaper accounts, this one from Politico, but one of the things that happened in 2015, I think, in the Obama administration was they required a more thorough, maybe, transition from one administration to the other, and this was legislative change. But one of the things they did was require better tabletop simulations, and in these simulations, what happened was the outgoing administration had its representative, its equal representative to the incoming administration sitting next to each other doing these tabletop simulations. And this one, it turns out 7 days before this administration took office, there was a tabletop simulation about a pandemic. And this is apparently what they were told. They faced a major test, the rapid global spread of a dangerous virus in cities like London and Seoul, one serious enough that some countries were imposing travel bans. Trump's incoming team learned that the disease was an emerging pandemic, a strain of novel influenza known as H9N2, and that health systems are crashing in Asia, overwhelmed by the demand. Health officials warned that this could become the worst influenza pandemic since 1918, Trump's aides were told, and then soon they heard there are cases popping up in California and Texas. This is eerie. It looks prescient at this point in time. The question was raised by this newspaper was how much of the original simulation team was even present anymore at the beginning of this pandemic, and I tried to confirm it, but it's really even difficult for me to find the names of the people who were present during the simulation. It was estimated that by this newspaper that 2/3 were now gone, and much to my chagrin and embarrassment, I feel bad that the United States did not lead this pandemic rescue mission as it has in every other one since 1918. These are some numbers in Illinois. You don't even need to see the numbers. You can see that it starts to look like a curve. And this was, again, from March when I first gave the talk until May. And you can just see the increase in deaths and cases. This is the case of positive results. This was interesting because it's from the website IDPH, which is the Illinois Department of Public Health website from April 3. And it was showing that roughly 20%, 21% of our population was testing positive, which was kind of the initial numbers I had heard coming out of New York City when they were checking for antibody tests. So that's kind of nice confirmation to have, given that every state has been using different testing. This is the data from New York City, from the New York Times. General population approximately 20%. Healthcare and frontline workers fewer, probably because of personal protection and possibly because of more implementation of public health recommendations for decreasing transmission. So I am going to spend a little time on that today. This is a funny cartoon. This is in Illinois again, testing positive by age group. You can still see that a large percentage of middle-aged people are testing positive. This is by race and age, so the same age curve on a different date with race and ethnicity. Brown color is Latinos or Hispanics. Orange are the African Americans or the Black population. The white one, the blue ones are the Caucasians. And this is a different way to look at it, slightly easier. And I'm showing this because if you look at the, sorry, as I'm pointing at the screen, you can't tell, but if you look at this, you can see a large percentage of Hispanics, slightly smaller, but still large percentage of whites and blacks. Now look at these three triangles because these are confirmed cases by race and ethnicity. And then look at the deaths. So the blue, which is the white population, has a disproportionately large number of deaths. The black population also has a slightly larger proportion of deaths. The Hispanic group is smaller, and I don't know, I don't have this data over time. I don't know if it's because they were getting infected later, and so, you know, the death numbers hadn't caught up. If they're living in enclaves with a slightly milder strain, if they take better care of themselves, if it's different genetics, I really don't know. But it's a really interesting difference. Sorry, this came out at the beginning part when everyone was, I guess, still hoarding toilet paper. Okay, so what is coronavirus? It goes by a lot of names. Coronavirus, or the 2019 novel coronavirus, which is abbreviated 2019 nCoV. COVID-19, which I've used maybe the most when I speak about it. CO standing for corona, VI for virus, D for disease. The 19 is for 2019, COVID-19. And maybe most importantly, this is a SARS virus. And I bring that out because it's one of those things where, was it Harry Potter where it says you have to name your enemy? Without knowing that it's a SARS virus, it really starts to sound really, really novel. And what I'm going to show you is it's not the first time we've seen SARS. The coronavirus is a small virus particle. They call it a spiky ball. It's got a little set of RNA inside and is surrounded by a sphere of fatty lipid molecules. It's in the beta lineage of the beta coronavirus. And it's important to realize that this virus cannot survive long without a body to live in. I say this because, again, there's been all sorts of stuff talking about how long this virus lives out of this and on that, but really, as far as viruses going, it's relatively fragile. Here's the RNA, the lipid layers, and then these spikes. Now, those spikes are important. These spikes recognize and stick to ACE, which is angiotensin converting enzyme 2. Which is a protein found on most cell surfaces or on the cell surfaces, and it's the first step to infection. So first it finds the ACE2 and then it sticks to it, all right? And once it sticks, then what? I'm going to back it up a minute because SARS classic, this first SARS, I don't know if people remember, there was a SARS pandemic in 2003. US was prepared and not much happened here. But the SARS classic had to actually mutate to become a virus that recognizes ACE2 inhibitors. This spike that sticks to the ACE2 is actually two connected halves, And the spike gets activated when the bridge holding those two halves together separates. And then once that happens, the virus can go into the human cell that it's stuck to. In SARS Classic or SARS-1, the separation was very difficult. And this is the big difference. In the SARS virus we have, SARS-2, that bridge is very easily separated by furin. I'm going to come back to that in a minute. So SARS-2 sticks to the ACE inhibitor to the ACE2 much better than SARS Classic did, and that's crucial for person-to-person transmission because the tighter the bond, the less virus is actually required to start an infection. And then the basic amplification calculation, which is a contagiousness kind of a scale, if for the flu is found to be 1.5, and for coronavirus is thought to be closer to a 3, which makes this a very infectious particle. Remember I said it was relatively fragile? These lipid shells are easily torn apart by soap. All you need is 20 seconds of hand washing to break it. And then it's very vulnerable to the elements. It only, not a lot, it only lives 1 day on cardboard and 2 to 3 days on steel and plastic. Remember, other viruses live longer. Coronavirus in general, only 7 members can infect humans or are known to infect humans altogether. 4 of them are responsible for about a third of our common colds. And 2 can result in more severe disease, MERS and SARS, which is SARS Classic. And then the 7th one is SARS-CoV-2 or coronavirus. This virus is extremely stable. There are at least 100 mutations that are documented, and none of these mutations is dominant, which means none of them is especially important, with one exception, or maybe more, but at least one exception. Some of the SARS-2 viruses from the original epidemic or pandemic, when it came from Singapore, was missing a little chunk of genes, genetic material that also disappeared from the original SARS virus in the late stages of the disease or of the pandemic. And with that clip missing, it's thought to actually make this virus less virulent. Now, I don't know if that's what's happening with our survival rates that I showed earlier. I'm not sure. The closest wild relative of this virus is found in bats. There was a lot of reports at the beginning of Asian bats. SARS-1 actually was also thought to come from different bats, but these are all different kinds of Asian bats, some of them cuter than others, this one positively frightening. COVID-19 has 96% homology with the bat coronavirus at the gene level. That's important because when you start tracking how much of a virus matches something else, it sort of shows where it may have come from. Another animal that was bandied about at the beginning were wild pangolins, and they do carry a coronavirus that resembles SARS-2, but it's only in the small part of the spike that recognizes the ACE2. Otherwise, it's not similar. This, by the way, in case you don't know, the pangolin is a mammal with scales, and it's like an anteater in that it eats ants, and its tongue, which is amazing, apparently is as long as tip to tail of the animal itself. I guess it eats termites too. So how does the coronavirus attack? And again, I think this is important. You have to realize that most respiratory viruses infect either the upper or the lower airway. The upper is usually from like the neck and above, and the lower is from basically the lungs. So what's interesting is that an upper respiratory infection spreads more easily, but it's milder, whereas a lower respiratory infection tends to be harder to transmit, but it's usually more severe. SARS-2 infects both upper and lower airways. And the question is, does it spread while it's in the upper airways, and then it spreads to go deeper to cause symptoms? So by the time you realize you're sick, you've already spread it everywhere. I'm coming back to this slide because remember I said that SARS-2, this bridge connecting the spikes, is easily separated by furin. Well, furin is an enzyme that's made by human cells, and it's easily accessible to this virus. So basically, once it sticks on an ACE2, it finds furin, which is pretty easy to find. It separates the spike opens and spits the RNA virus into the cell that it's now infected. Well, so then what? This is an important part. SARS-2 affects humans by attacking these cells, and then as these cells die, they slough away, the airways fill with junk, and then the virus goes deeper towards the lungs. Meanwhile, the lungs are clogged. The lungs are clogged with dead cells and with fluid. Um, and you get pretty sick. So what I pointed out early in March, and sadly seems to be true, it makes sense that other ACE2 bearing cells can be affected. It's just that the lungs are kind of the first ones that get hit by the virus as they come into your body. And I think it's also important to note that it's not really the virus that's killing people. It's our body's response to the virus, meaning we get a virus, it's like if you get a cut and in comes viruses or dirt or whatever, and out comes pus, which is a whole bunch of white blood cells fighting to get those things gone, whatever the invader is. Well, this is what's happening in your lungs. You get a virus in, your body starts to recruit all of its help to try to get rid of the invaders, and then you clog yourself up with your inflammation, your inflammatory response. In severe cases, your body overreacts so badly that it does something called, it goes into something called a cytokine storm. And this cytokine storm is actually responsible for a lot of deaths in many of the pandemics and flu. All right. So I'm not going to go over this. I've gotten rid of most of my medical slides. But just so you know, most people have already seen this, but at the very beginning, we were looking for every scrap of data we could find. People were presenting with a fever and dry cough, although now there seem to be variations on that. And I think medically at the time, because this was medical grand rounds, it's interesting because we were seeing patients that were, normally when we talk about being tired in disease, we call it fatigue, but nobody was talking about fatigue. Everyone was talking about exhaustion, how tired they were, but exhaustion and lasting for a long time, shortness of breath. It came out that there seemed to be an early loss of smell and taste. There was some diarrhea. Just to go back to cytokines, there are 5 kinds of cytokines, which are easily found. There are different subtypes of them, of course, but these cytokines are actually messengers from one cell to the other. White blood cells, which fight infection, send cytokines when they need help from other cells, and depending on the kind of help they need, they send that kind of messenger, usually one of these 5. Cytokine storm is an overproduction of immune cells and their activating compounds, which in a flu infection is often associated with a surge of activated immune cells into the lungs. Treatment, I'm just going to run over this because this is changing rapidly and I have to be optimistic that it's going to get better. The basic one that I want everyone to be aware of is the non-pharmacologic treatment, because at this point, that's all we have. There's testing, which if you can do it early enough, you can isolate cases to prevent transmission. Cat's out of the bag of that one. There's antibody testing, which helps in identifying who's had it and recovered. For instance, if healthcare workers who can then safely go back to the front line without being afraid. There is isolation or social distancing, which probably everyone is quite familiar with at this point in time and may be sick of it. I've got data here from the National Geographic from the 1918 flu, which someone plotted out. At that time, New York City was your prototypic good, ideal curve. They found out, they isolated, and the case stayed isolated, and pretty much the peak went away. They started 11 days before the death rate spiked, and they had the lowest death rate on the eastern seaboard. Philadelphia started to isolate, but not until later, and so they did it 8 days after they began to have a higher death rate, and their death rate super spiked, but then they stayed isolated. San Francisco isolated early, but then they lifted their quarantine too early, and they got a second peak. In St. Louis, they didn't really believe in social distancing, and they got their peak and it just increased, and it went away. So it sort of shows, as researchers keep showing, the importance of social distancing. I'm going to go into this a little more later. There's masks, hand washing, and surface cleaning. Please remember these. These are our non-pharmacologic treatments, and that's what we as people on the street can do. Social distance, masks, hand washing, and surface cleaning. Until we get a vaccination, this is what we have, or medication, or multiple medications. Possible scenarios, this was predicted by NPR on April 22. So their best scenario was moderate to high severity transmission with high asymptomatic transmission, which would lead to 94,000 deaths. We're obviously past that already. Their worst scenario was a very high or high severity and transmission with a low asymptomatic transmission, which would give you almost 2 billion deaths. Hopefully we're not going to get there. We are, I guess, well on our way to scenario 1 and possibly on our best guess. The best guess predicting 302,000 deaths. And remember, in 1918, we had 675,000 deaths in the United States. Social distancing, I'm just bringing this up as a sidebar. I said I'd come back. This is why. Why is 6 feet so important? Everyone, all the stores have this tape. Well, it's based on WHO data from somebody named Wells in the 1930s who was studying TB. For those of you who don't know, in medical school, they teach you about fomites. They might teach it other places. I don't know. I'm only familiar with my school. But a fomite is when you speak and you're talking to someone who, enunciates their P's really well, and little bits of spit, sometimes bigger bits of spit, go flying. These are called biggish particles, which are more than 5 microns. And they predicted at that time, studying TB, that you needed to be at least 3 feet away from somebody else. This 3-foot distance was revised by CDC based on the SARS pandemic in 2003. And they thought, well, a phone might actually travel 6 feet, not 3. And if you're not wearing a mask and you're sneezing and coughing, it might go 23 to 27 feet, hence the mask. Obviously, if you're not around anybody, there's really not any real need to wear a regular mask. And remember that the N95 mask is meant to filter out viruses, but the 95 stands for 95% effectiveness. Aerosolized. There's a question out right now still on whether the SARS virus can be or is aerosolized, aka airborne. For instance, we know that certain patients who are on ventilators and at certain times with the ventilator, it's easier to make the virus particle go airborne rather than others. But the question is, does it do this on its own without something like a ventilator in place? And JAMA writes about it in one of their opinion pieces published in March. This was sent to me by one of my sisters. I thought it was very funny because social distancing and isolation seems to be the best solution right now. Okay, we're headed into the home stretch. I won't be much longer, I promise. Pharmacotherapy, at this point, there are no medications that are proven effective against SARS. I'm going to modify that because within the last several days, it looks like, based on a New England Journal article, that remdesivir, the original antiviral I mentioned that China was trying to patent, looks like it seems to shorten the length and possibly the severity of the virus. I'm not going to do a full analysis of the article right now, but it looks like it has some positive effects, which isn't surprising, right? Against the virus, it's an antiviral. I wanted to mention this because that's why I said it's important to name your enemy. SARS-1, which no one even knew when it said coronavirus all the time. SARS-1, the pandemic, they found 121 drugs and natural products that were successful against this infection. And I think that's really important. These were the 121. There are lots of them, but you'll see definitely they have antivirals, they have things that target the ACE, and they have things that target the cytokine storm. These are other drugs that were, other drug studies that were registered with the NIH in March when I was first preparing this talk. This thing has increased probably at least tenfold, but it included mushrooms, which are natural substances, obviously antioxidants, traditional medicines, non-steroidal medications, ACE2 inhibitors, remdesivir, the antiviral, DAS-181, hyperimmune plasma, and then an IL-6 inhibitor, Kevzara, which is the same as Actemra. Sorry, I think Actemra, anyway, at this time it was not on clinicaltrials.gov, but this is an IL-6 inhibitor, which is looking at cytokine storm. I want to thank my colleagues for their help and support in this, and that's the end. Thank you so much for listening.